Hello guys, this is group 6 and our topic is liver and muscle. Liver function test. What to consider when you are doing liver tests? Parameters are not equally affected by disease, serum abnormalities seen only after extensive damage to liver, and functional impairment may occur before lesion or vice versa. There are two basic groups of tests for assessing liver function. The first one is screening test. It is to detect occult liver disease, evaluate patients with clinical evidence of liver disease, as an assessment on the cause of disease and therapy. The second is specific purpose test. It is done after positive screening tests used to identify abnormalities which may be due to leakage of enzymes from liver parenchyma, cholestasis, or reduction of functional mass. Leakage enzymes. Hepatocellular leakage enzymes are useful in detecting injury to liver parenchyma cells and generally increased serum activity represents enzyme leakage from cells through damaged cell membranes. Alanine aminotransferase, also known as ALT, is a cytoplasmic enzyme found mainly in hepatocytes. ALT is the most liver-specific enzyme. It is released into the circulation when there is hepatocyte necrosis or increased cell membrane permeability, and therefore is a sensitive marker of hepatocellular injury. Aspartate aminotransferase, or known as AST, is not liver-specific. It is present in liver as well as skeletal muscles and erythrocytes. It is also a cytoplasmic and mitochondrial enzyme found in hepatocytes and other cells. Lactate dehydrogenase, or known as LDH, is non-liver specific enzyme. It is an enzyme that catalyzes the conversion of lactate to pyruvate. It is also non-tissue specific, being found in a variety of tissues including liver, heart, and skeletal muscle. Sorbitol dehydrogenase, or known as SDH, is found in the highest concentration in the liver, but it is not liver-specific. It is a cytoplasmic enzyme that catalyzes the conversion of fructose to sorbitol. It is a very specific indicator of liver disease in all species. Now let's see interpretation of each enzyme. When AST is elevated, it may indicate hepatitis, heart problem, pancreatitis, or renal infarction. When there is elevated ALT, it may indicate hepatitis, diabetes, bile duct problem, congestive heart failure, or jaundice. When the SDH is elevated, it may indicate hepatitis or pancreatitis. When LH is elevated, it may indicate heart problem, renal infarction, hemolytic anemia, or megaloblastic anemia. Next will be cholestatic enzymes. Gamma-glutamyl transferaminase can be found in the liver, kidney, and bile duct. It is a hepatic microsomal enzyme. ARISE can indicate cholecystitis, pancreatitis, or liver necrosis. It is useful in diagnosing cholestasis. It is used in conjunction with ALP for a better diagnosis. Alkaline phosphatase hydrolyzes monophosphate esters. It has the highest activity in liver, bone, intestines, kidney, and placenta. It has at least 8 isoenzymes with short half-lives. It is useful in small animals diagnosis, increases greatly due to hepatobiliary obstruction, and can also increase due to bone disorders. Hyperbilirubinemia. Can be due to prehepatic causes, which include increased bilirubin production, increased erythrocyte breakdown due to hemolytic disease or internal hemorrhage, increased bilirubin concentration, which overwhelms hepatic uptake. It can also be due to hepatic causes, which is due to loss of hepatic function, anorexia, or fasting, or sepsis. Lastly, it can be due to post-hepatic causes, which include decreased secretion of bilirubin into bile or physical obstruction of bile flow. It can also be due to other causes such as ineffective erythropoiesis or effect of antibiotic and tranquilizers. Unconjugated bilirubin can be seen mainly in prehepatic and hepatic hyperbilirubinemia, whereas conjugated bilirubin can be seen mainly in the post-hepatic hyperbilirubinemia. There are two types of tests for portal blood clearance. The first one is ammonia and ammonia tolerance test, and the second one is total bile acids. The protocol for ammonia and ammonia tolerance test. First, the animal should be fasted for 12 hours before sample collection. Inform the laboratory in advance to allow time for special transport and storage measurements to be prepared. Check the animal closely for any evidence of hepatic encephalopathy. Note that administering ammonia can exacerbate symptoms. Collect a resting sample into an EDTA or heparin tube. The sample needs to be immediately centrifuged, plasma separated, and stored on crushed ice or dry ice. Then, administer 100 mg per kg of ammonium chloride per rectum, more than 5 cm proximal to the anal sphincter, and remain for 5 minutes. Collect further blood sample into an EDTA or heparin tube for around 1 ml 30 minutes following ammonia administration. Also need to be immediately centrifuged, separated, and stored for transport to the laboratory. For total bile acids TBA, it may be measured after a 12-hour fast, 2 hours postprandially, or both. It has a similar procedure as ammonium tolerance test, but it is easier to perform and less dangerous for patients with hepatic encephalopathy. The meal provided to the patient should contain lipid to provoke a strong cholecystokinin stimulus for gallbladder contraction. Here is some extra info about total bile acids. Not all patients with liver disease have elevated TBA. Some gastrointestinal lesions may slow the delivery of bile acids to the ileum and therefore lower the postprandial level. Ileal disease leading to malabsorption will lower the reabsorption of enteric bile acids. Bacterial overgrowth will increase conjugated bile acid levels and falsely increase reabsorbed bile acid levels. In hyperbilirubinemia condition, the bile acids will rise due to cholestasis and competition between bile acids and bilirubin for the same excretory pathway.
Now let's move on to the case study. By now, we already know ALT is a liver enzyme and ALP and GGT are cholestatic enzyme, and this is particularly true in canine species especially. This is the case study taken from NCBI website, a descriptive study of histopathologic and biochemical liver test abnormalities in dogs with liver disease in Thailand. In short, this study, which involves 87 dogs, describes the sensitivity of the enzymes in relation to the different conditions of liver diseases, namely inflammatory disease, neoplasia, regressive change or degenerative change, and circulatory disturbances. This is the hematology and biochemical reports in dogs with liver lesion. However, we will be focusing on these parameters especially. We can see 48.3% of the dogs have an elevated ALT level, 77% have an elevated ALP, and 55.3% have an elevated GGT level. In this table, we can see that 59 out of the 63 dogs with inflammatory liver disease were reported to have 2 times elevation in ALT and or ALP. 9 out of 10 dogs with regressive change or degenerative change were reported to have also 2 times elevations in ALT and or ALP. Meanwhile, only half of dogs with circulatory disturbances and liver tumor were reported with 2 times elevation in ALT and or ALP. So, liver enzymes are a useful marker to diagnose inflammatory and regressive or degenerative liver lesion. However, not all inflammatory and degenerative liver lesion will have elevation in these enzymes. 2 to 3 times elevation of the enzymes are considered diagnostically significant.
Next, muscle enzymes. We have creatine kinase, aspartate aminotransferase, alanine transaminase, lactate dehydrogenase, aldolase, and myoglobin. Among all the enzymes, creatine kinase is very specific and very sensitive, whereas myoglobin is useful in urinalysis. Creatine kinase. Creatine kinase is a cystosolic enzyme which can be detected in kidney, GIT, uterus, thyroid gland, and urinary bladder. It has 3 isozymes which are MM, MB, and BB. It has a 2 to 4 hours plasma half-life, elevated during muscle damage, decreased in muscle atrophy, and back to normal within 24 to 48 hours. CK, AST, and LDH increase mildly in exercise and vigorous training. Elevation of CK in cerebrospinal fluid indicate encephalomalacia and compromised blood-brain barrier. It is also used with AST to determine the prognosis. Aspartate aminotransferase. Also known as AST, it is found in the liver, cardiac muscle, and skeletal muscle. It is a non-specific indicator for muscle injury and has a longer half-life than CK with average 50 hours in the serum. AST elevates in hepatic insufficiency, skeletal myopathy, and hemolysis. If other liver parameters are normal, increase in serum AST levels indicate muscle disease. Lactate dehydrogenase or LDH is not organ-specific. Increase in muscle diseases, hepatic diseases, hemolysis, and tissue necrosis, rarely measured in small animal, less sensitive towards muscle injury, and maximum serum activity reached in 48 to 72 hours. Aldolase. Aldolase is less specific for muscle, no advantage over CK and AST, not sensitive towards muscle injury, and rarely measured in small animal. Alanine aminotransferase. They increase in severe myonecrosis, often occur together with CK and AST elevation. The half-life of ALT is about 2.5 days. They are less specific and sensitive. Myoglobin in urinalysis. Specific indicator of severe skeletal muscle necrosis or damage. Myoglobin cause brown discoloration of urine, subsequent acute kidney injury which leads to increased renal parameters can be differentiated from hemoglobinuria by addition of ammonium sulfate and very sensitive to muscle injury. In summary, muscle injury will have elevated CK, positive myoglobinuria, and also increase in the AST, ALT, LDH, and aldolase level.
Now, let's move on to the case study for muscle enzyme. This is a case study I get from NCBI website. measurements of creatine kinase and aspartate aminotransferase in saliva of dogs, a pilot study. Purpose of this study is to assess if CK and AST activities that are measured in the saliva are as accurate as the one measured from serum. In short, this study involves a group of healthy dogs which act as a control group in order to obtain the normal range to be compared with dogs with muscle lesions, and a group of dogs presented with inflammatory and/or degenerative muscle lesions. Salivary and serum CK and AST were then measured from these two groups of dogs. These are the results obtained, and although this unit is not the same as the one we've been taught in class, we can still see the comparison in the values, in which serum CK in healthy dogs is 57.9 to 239 unit per liter, while dogs with muscle lesion is 319 to 78,650 unit per liter, while for the salivary CK 27 in healthy dogs it is 27 to 121 unit per liter while in dogs with muscle lesion it is 132 to 3,862 unit per liter. So we can see that serum CK and salivary CK, they both shows increment in the value of CK when the dog is associated with lesion in the muscle. Same goes with the aspartate aminotransferase AST values. You can see both in the serum AST and also in the salivary AST, there is an obvious twofold, threefold to even fourfold increment in the value of these enzymes in the dogs with muscle lesion. So from this study, we can see that serum CK and AST increase in dogs with inflammatory and degenerative muscle lesion. Serum CK and AST are in normal range in healthy dogs, meaning we can see from the dogs from the healthy group, the serum CK and AST are in normal range. And although not in our syllabus, it is very interesting to point out that saliva, CK, and AST can be a potential alternative to serum due to its non-invasive collection. But however, further studies need to be done in the larger populations of dogs.